but my name is Sara Teresa Jonsdottir. I am a student of clinical psychology at the University of Iceland. And today I will be presenting to you results from a scoping review that I have been working on with a team of researchers from the University of Iceland and Lund University in Sweden. And in this scoping review, we examined the relationship between culture and the end user trust in electronic health interactions, which I will refer to as Ehealth in this talk. So Ehealth trust is an elusive concept. It's not a behavior, but it's rather a psychological state concerning individuals' perspective of privacy. It is also defined in individuals' trusting belief, that is his willingness to become vulnerable to the actions of another party, as well as his attitudes towards the protection and use of their electronic personal health information. In the Ehealth trust model by Shen, depicted on the slide here, it shows that Ehealth trust is conceptual and informed by antecedents like culture. It also shows how together Ehealth trust and antecedents are significant determinants in patients' behavioral reaction to health information exchange. But what is culture? As the cultural iceberg model here on the screen shows, culture is the hidden variable that is mostly unnoticed by us. But it is a variable that significantly influences thoughts, feelings, and behavior of individuals. There are, of course, many different kinds of culture. Culture can, for example, be geographically based and focused on familiar distinctions, such as the East versus the West. But it also encompasses other distinctions like social class, ethnicity, gender, or immigration status. These different kinds of culture can be mapped and analyzed using the cultural cycle you see here on the screen. So when people interact with other people and with human-made products, they follow norms about right ways to behave. The ideas of what is right, good, or moral are often invisible and historically derived, and inform institutions, interactions, and ultimately the individual. So culture can serve as a label for any significant category associated with a set of shared ideas, practices, and products that structure and organize behavior. Patients' trust in various aspects of traditional healthcare is known to be an important factor in healthcare utilization, quality of care, and health outcomes. Without trust, patients may, for example, withhold information or even avoid seeking care. And evidence also shows that an important relationship exists between culture and trust in patient-provider communication. But less is understood about this relationship within Ehealth. And this is problematic as Ehealth creates unique challenges for all stakeholders and indisputably adds complexity to this trust relationship. And it's also problematic because trust is a prerequisite for Ehealth's success. As I mentioned earlier, in the Ehealth trust model by Shen, culture is an antecedent of Ehealth trust. It is, however, unclear how and to what extent culture relates to this complex relationship, as our current understanding is predominantly within traditional healthcare and not e-health. And this is important to know in order to build sustainable e-health solutions that foster trusting interactions. By mapping the literature, we hope to contribute to creating a coherent understanding of this relationship, as well as identifying gaps and informing future research. We chose to use the scoping review methodology because it has proven effective in capturing broad and ambiguous topics such as e-health and culture. Our data search included 3 databases, and our search strategy involved formulating appropriate keywords for our 3 main concepts, which are e-health, culture, and trust. And for our data search, no boundaries were set for publication type, year, or language. We developed our inclusion criteria based on the participants' concept context guidelines recommended by the Joanna Briggs Institute. We defined our participants as any end users of e-health, regardless of characteristics such as age, gender, cultural background, etc. And we included studies needed in some way to address the relationship between culture and trust in the context of e-health interactions by the end users. So we did not include studies that focused on the healthcare providers, organizations, development of e-health, etc. And we did not put limits on the types of e-health included. And here you can see the flowchart of our screening process. Our search has yielded a total of 1,129 titles. Of these, 19 were duplicates. First, we screened the titles and abstracts of all articles, of which 152 were eligible for a full text screening. And after the full text screening, 40 articles were included in the study. And on this slide, you can see the information we extracted from the included studies. And to analyze this data, we used a descriptive and thematic approach. And now for the results of our review. Of the 40 studies included in the review, majority were qualitative and quantitative studies, but we identified a few mixed design studies and reviews also. Overall, the studies were conducted in 12 countries, a very large majority of which were Western countries. We identified 4 types of healthcare, that is e-health, online health information, telemedicine, and mHealth, which is mobile health. In majority of the studies, culture was not directly measured or defined, and the authors mostly relied on self-reported cultural groups as measurement. The most common cultural variables studied were ethnicity and race, but age was also commonly studied, particularly the elderly population. Other cultural variables we identified were gender norms, sexual minorities, historical mistreatment and stigmatization, and minority populations such as immigrants, migrants, and refugees. Socioeconomic factors were also studied, such as income and education. The stakeholders we identified in eHealth included both patients and public end users. So through thematic analysis, we identified 3 categories of end users' trust in e-health interactions that related to culture. These are self-trust, relational trust, and institutional trust. And as you can see on the slide, these 3 categories of trust are interconnected. And in most cases, the cultural variables we identified influenced more than one category of trust. So as I present the results, I will define each category of trust, while also showing the interconnectedness between the categories. So our first category of trust is self-trust, which describes an individual's belief and confidence in their own skills, ability, and competence to effectively use e-health services. And this includes trusting that you have the capability to access and interact with e-health services, assess the quality of health information, understand it, and apply it appropriately. And here within the circle on the screen, you can see the cultural variables that interacted with self-trust, and also how they relate to the other categories of trust, which are displayed at the bottom of the slide. The finding that we find the most important regarding self-trust is its relation to gender norms. And interestingly, this is the only cultural variable in self-trust that's based on research from a non-Western country. This study found that women in Bangladesh felt unable to partake in certain activities within a e-health intervention because they were perceived as socially inappropriate for women, and the activities made them feel uncomfortable and unsafe. Women also felt constricted by family commitments, whereas men had more freedom to partake in activities outside the home. And now our second category, relational trust. It describes end users' trust in direct e-health interactions, such as interactions with healthcare providers through e-health and interactions with health-related information and content. So basically, relational trust describes trust in what you see and hear during e-health interactions. Relational trust towards healthcare professionals includes believing that the person is truthful, reliable, has your best intentions at heart, and will treat you with respect. Relational trust towards electronic health information, interventions, or services includes feeling that they are reliable, unbiased, safe, beneficial, and appropriate for the individual. And these are the cultural variables that interacted with relational trust. The majority of studies in this category regarded historically stigmatized or mistreated populations in Western countries. These are populations such as sexual, ethnic, and racial minorities, as well as individuals with stigmatized conditions. We found that these populations often enter healthcare interactions with negative trust because of former negative experiences. However, each of these groups has their own needs that need to be considered in order to enhance relational trust. For example, individuals with stigmatized conditions, such as HIV, have a need for anonymity and privacy in their e-health interactions. For racial and ethnic minorities that have experienced historical mistreatment, e-health can bring specific challenges that need to be addressed. For example, one study reported that African Americans, because of their experience of discrimination and mistreatment, often feel the need to see and monitor their healthcare providers to be sure of getting quality service. In these instances, e-health services that limit opportunity to monitor providers can increase insecurities and distrust. For indigenous populations, culturally appropriate language use, as well as family and community involvement in healthcare, enhanced relational trust. For these populations, enhancing interdependence was more important than enhancing independence. And this is very important to consider in relation to e-health, because in Western healthcare, e-health is often geared towards end-user independence. And this can lead to poor cultural usability for individuals with communities, individuals or communities with interpersonal values. We also found that an important factor to consider in e-health is provider end-user likeness. And this is the cultural, behavioral, and physical similarity between an end user and the healthcare provider. Likeness has been found to enhance end users' relational trust, both in interactions with real providers, but also in interactions with virtual healthcare avatars. And this is especially important for minority populations, where cultural representation in healthcare is often low. And now our last category, which is institutional trust. That is the belief that institutions have your best interest at heart, care about your well-being and safety, are reliable, unbiased, and operate on principles of equality. And by institutions, I'm referring to healthcare systems, organizations, developers, as well as governments and regulatory institutions. Among historically mistreated and stigmatized populations, past events have resulted not only in mistrust towards healthcare services or providers, but in general mistrust towards healthcare systems, organizations, and policymakers. Our results also suggest that this institutional distrust is present among individuals with low literacy, education, and e-health literacy levels. And to enhance this institutional trust, our results suggest that healthcare institutions should offer culturally appropriate services. And this can, for example, be achieved with community involvement in the development and implementation of e-health services. And here you can see all three trust categories and the cultural variables that interact with them. And as you can see, most cultural variables interacted with more than one category of trust, which highlights the interconnectedness between them. In our review, we discovered that all three kinds of trust can be enhanced with the use of culturally sensitive and culturally appropriate e-health services. And it's very important that, that these services are tailored to each individual's cultural needs. Language, for example, can be both culturally sensitive with regards to vocabulary, for example, and it also has to be appropriate for individuals' ability levels. Anonymity can both enhance and reduce trust based on the end user. For stigmatized populations, for example, anonymity enhances trust and safety, while for many elderly individuals, the anonymity of e-health feels very impersonal. And cultural appropriateness can involve emphasis on cultural likeness between healthcare provider and end user. And this can, for example, be achieved with the use of culturally appropriate avatars. And lastly, it's important to accommodate the end user's values in e-health services. These are values such as independence versus interdependent values, family and community values. This also includes anticipating the effects of restricting gender norms and power structures on e-health interactions. To summarize, our review does indicate that e-health trust and culture are related constructs. And perhaps most importantly, we found that culture and cultural experiences can bias end users' e-health trust towards negative trust. And this has to be met with culturally sensitive and appropriate services. But because quite few articles were identified, probably because the research subject is quite young, evidence was dispersed, making any definitive conclusions difficult at this time. We did, however, identify gaps in the literature that can guide future research. First of all, in majority of cases, current research does not define culture and relies only on cultural and demographic groups as measures of culture. Secondly, little or no research exists on key groups of end users, such as children and caregivers. And furthermore, results are very much skewed towards Western cultures. And lastly, cultural appropriateness of e-health interventions was most often evaluated after its implementation, rather than mapping cultural needs of end users as part or before the design process. Thank you very much for listening. Feel free to ask any questions, or you can also send me an email if you prefer.